This next speaker is no doubt another very interesting talk and a topic that I want to spread that education on as much as possible. Dr. Justyna Swol is a clinical scientist, Institute Department of Respiratory Medicine, Allergology, and Sleep Medicine at the General Hospital in Nuremberg, Germany University Hospital. Her research expertise is in extracorporeal life support, pulmonary and cardiac support, extracorporeal devices, artificial lungs, intensive care medicine, trauma, and resuscitation. She is also interested in simulation training and medical education. She's on the editorial boards of so many journals, including the Great Osayo, and as well as an associate editor. She's a reviewer on many different journals as well. You can read this in our agenda bio book and everything. But Dr. Swol's presentation today is entitled Weaning from VV Ecmo, Venous Ecmo, Life Support for Respiration. I personally love this subject as I travel to so many Ecmo programs and find there is little consistency in weaning techniques between institutions, not to mention physicians within those individual institutions. So the presenter with the greatest smile, my friend, Dr. Swol.
Thank you. Thank you, Bill, for this nice introduction. And I would like to speak about weaning strategies because it's also the one of more important parts of weaning, or of weaning is one of the most important parts of ECLS management, because it's not enough to put the patient on the ECMO. You have to, of course, you have to wait to lung recovery, but there are so many pitfalls according to weaning and decannulation, and let's talk about this one. So I do not have any conflict of interest to declare. The goals of respiratory support on VV ECMO is to provide oxygenation and CO2 removal. It's an artificial lung. Also, we are talking about lung protection and lung rest. So we understood it over the years. That's very important, not only to remove the oxygen, but also to protect the lung, to remove CO2 and to put the oxygen into the patient. But we need to protect the lung and enable the recovery. Of course, over the time of support, we also minimize the extracorporeal support. This is the most important step in the weaning procedure. We minimize it to the lowest level needed to maintain gas exchange. And then finally, we want to wean and decannulate the patient. At this moment, we also should take into consideration that decannulation doesn't mean, or weaning doesn't mean the pure discontinuation of ECMO, because as you may see in this algorithm of understanding ECLS for respiratory support as a bridge. If the bridge, it's the bridge to nowhere and it's no destination and futility, it's just disconnecting the ECMO or ECLS. But in case of no lung recovery, if it's no recovery of the lung. But in case, if we wait long enough and have the prolonged ECLS run, and maybe in the future perspective also more possibilities in the support as an artificial lung and a lung transplant, it's a long, prolonged process, and then we still wean the patient. But this ECLS, this daily routine as ECLS for respiratory support as a bridge to lung recovery, if we have a run about even 14 days or 21 days, and we attempt to wean the patient, we have to know the weaning process. It's not only weaning from Ecls, but it's the combination between mechanical ventilation weaning and Ecls weaning. And you will see in the second part of my presentation, a survey we performed, and we asked the physicians how they wean and what do they prefer to wean, mechanical ventilation first or to wean Ecls first. So there are several recommendations about weaning procedures, and one of them, the earliest one I have found, and a really nice from Karolinska and from Italy and Regensburg from Maximilian, is about kind of balance between membrane lung and natural lung. And of course, this is what we all know, that weaning starts with the improvement of the natural lung. And then improving the gas exchange should be monitored, and the weaning process should focus on keeping the balance between natural and membrane lung in case of weaning from the Ecmo. The weaning from mechanical ventilation is not really mentioned in this paper. The authors focus on weaning from the Ecmo weaning and this how to keep the balance between membrane lung and natural lung. The second one is how I wean patients from Venous extracorporeal membrane oxygenation from the group Vasquez, Romiti, Gattinoni, and Luigi Camporota. And they explored a kind of, or developed a kind of a weaning test. As a first step, the Ecmo deoxy challenge test, if passed. As a second part, the Ecmo CO2 challenge test. And then to decannulate a patient after 24 hours if the CO2 challenge test has been passed. And this is a very interesting concept, but I believe it's too complex to be implemented in the really busy daily routine. But it's also based of this balance between the machine and membrane lung and the natural lung. So we all are talking about the same issue, how to keep the balance and when to start to resolve the membrane lung to benefit into the benefit of the natural lung. And of course, what's the most important thing to recognize when the patient is really ready to, even if we say, okay, weaning starts at the moment of the cannulation, we cannot wean the patient who is in an inflammation process, who is in a really inflammatory phase of ARDS. So the pretest criteria, like in this case, or weaning criteria should be disease resolution, maybe spontaneous breathing, what we don't know exactly if it's needed, and then the patient should be hemodynamically stable, and the pressure on the respirator, on the ventilator, should be less than 30. But as I said, it's what is recommended in this paper. And then we have a very nice proposal for the protocol, weaning protocol. The next group will publish in Artificial Organs 2018. And if we see all the steps, we also almost already talked about this, is like, again, resolution, underlying pathology, underlying disease, improving lung compliance, which means yes, resolving and the improving the function of the natural lung. Hemodynamic stability, also like proposed by the last mentioned group, no metabolic derangements, normovolemia, chest radiograph normalization. So all those are clinical recovery signs and assessment. And then how we should target a ventilator setting. So this group included the ventilator weaning in this whole weaning process, complex process. And I would really appreciate if we would have only awake patient on the ECMO, and then could discuss the singular weaning from the ECMO without the ventilator. But as you will see in the results of our survey, the majority of the patients are on mechanical ventilator at the time of ECMO weaning and discontinuation. So for this reason, we have to implement weaning from mechanical ventilation into the weaning protocol of VV ECMO and respiratory support. So also should be mentioned, the authors proposed daily weaning trial. I don't know if it's feasible, if we are talking about a very prolonged weaning or very prolonged time of respiratory support, which is more over 4 weeks, and the lung recovery it needs more time, and we know the longest time of VV ECMO for respiratory support was more than 600 days, and this is like a kind of artificial lung support, a very long lung recovery. And then the steps like wean ECMO flow, and then to switch sweep gas and check to obtain a normocapnia in arterial blood gas analysis. So summarizing all the recommendations from the manuscripts published reviews, we may recommend weaning of sweep gas flow and stepwise reduction to 0. We recommend adjust to the respiratory rate and FiO2 levels, and if the patient is on mechanical ventilation. So it's what we are talking about, this complex process and interaction not only between a membrane lung and nature lung, but also invasive mechanical ventilation. Then eventually weaning of extracorporeal blood flow parallel to the sweep gas flow to set a minimum flow. And the minimum flow is also the balance between the risk of thrombosis and clotting in the system and the risk of bleeding if there is a risk of in the patient who is on anticoagulation. So this is also a point which should be recognized and took into consideration, how to balance the risk to leave the patient on the ECMO or to remove the ECMO maybe a bit earlier if there is a risk of thrombosis of membrane clotting or pump clotting. Then we should monitor mixed venous saturation, and the steep drop may indicate a weaning failure. This is what one of the authors of the paper mentioned and recommended. And then what we also should have seen: stable hemodynamic condition, adequate oxygen and oxygen delivery, and no severe different organ failure. It means we cannot wean someone from respiratory support who is in a severe heart failure, or another point is maybe the renal failure, but because it's on the dialysis or hemodialysis, and we can manage this very fine. But heart failure is probably a contraindication, and maybe even the patient should be switched to VA ECMO or VA V combined support. So about weaning of mechanical ventilation and liberation from extracorporeal support, we may also say the ventilator setting appropriate to allow the cannulation vary from patient to patient because of the underlying disease. And we always aim lung protective ventilation before patient decannulation, because this is what we mentioned at the beginning on the presentation, what I mentioned. It means ECLS allows lung protection, and it makes no sense to remove ECLS if we destroy the lung with mechanical ventilation. So it should be taken into the consideration. Then PO2 and FiO2 ratio with mechanical ventilation should be above 100 without ECLS if we aim the decannulation. It doesn't mean we are also talking about lung protection, so it should not be FiO2 by 100% FiO2 on the ventilator, and normocapnia and pH more than 7.3, so patient should be in a stable condition. So what about patient who cannot be weaned? As we mentioned in our first slide with the algorithm to futile condition. So in the very early publications, nowadays we know 12 days of respiratory support, especially in the COVID patients, it's not a prolonged support. But the average VVSLS support was normally in non-COVID patient about 12 days. And we have had a survey, EuroELSO survey, so we put some recommendations about prolonged ECLS support, and we defined prolonged ECLS support as 21 days. And how to define, it's very difficult to define futility. So we know the duration of support does not predict futility. This is definitely what we should consider talking with the family and the patient. And there is also possible the full lung recovery after weeks and months on support, as mentioned, 600 days, the longest Ecmo. And what the difficulty is that ICU and ECLS related complications make prolonged runs difficult. This is what the patient has is suffering from, and what makes this prolonged run difficult. And about 30% of patient may not be able to be weaned, and this appropriateness about weaning should be reviewed regularly. So maybe not as a daily attempt, especially in the prolonged support, but maybe every 2-3 days. But it should not be like Ecmo is in, and we never check it, what's going on. But I suppose no one managed the patient like this, and everyone knows we should review the parameters regularly. So practice patterns and ethical considerations in the management of venous extracorporeal membrane oxygenation patients. Daryl Adams from New York performed with his colleagues an international survey and find out the factors most likely to influence decision to withdraw Ecmo support. So if weaning is not possible, and we are talking about withdrawal of extracorporeal support, and as we see patient comorbidities, but also patient wishes and underlying disease are the main factors influencing this decision. Maybe also patient's age, but I believe it's correlate with patient's comorbidities, availability of resources. It is what should not influence our decision, but sometimes, and I believe in nowadays, during the COVID pandemics, the influence of this factor has increased in some centers. And of course, legal constraints, financial considerations, hospital protocols. So the withdrawal of ECLS, as authors stated, the withdrawal for futility needs to follow local ethical guidelines with ongoing discussions with family and or the patient if the patient is awake. This is the background of futility situation and bridge to nowhere in case of respiratory support with ECMO. Then the next point is, as we know, VV-ECLS allows reduction in the power of invasive mechanical ventilation to provide improved lung protection. And there is the evidence in the praxis of liberation from invasive mechanical ventilation during ECLS is increasing. And this is what we all probably aim. And we feel probably it's better for the patient, but it's not always feasible. And the guiding in the weaning process from both ECLS and invasive mechanical ventilation is quite limited, as we have seen. 3 papers, weak recommendations. It's mostly it's not really evidence-based, and we do not have really. It's not cohort-based. It's just based on our experiences. So the evidence which group of patients benefit of weaning of invasive mechanical ventilation before ECLS decannulation is also very weak, and trials are needed. And the limitation of the trials are always the same. Randomized trial, it's depending on the local protocols. So such a survey will be very, such a trial would be very challenging, but I believe we will be able to plan such a trial maybe in the next 2-3 years, especially once the COVID pandemics is gone, and the normal life will come back to us. So next point, and this is the survey I was talking about at the beginning of the presentation. So we performed a survey, and we asked the physicians and ECMO providers, should we extubate before VV ECMO decannulation, or should we decannulate while remaining on the ventilator? We performed this survey during the last EuroSO conference, which was performed in person in Barcelona 2019. So the aim of this survey was to understand strategies currently used in weaning from VV ECMO and invasive mechanical ventilation. Survey characteristic. The survey was provided not only during the conference. It was around the conference, so it was about I believe 3 or 4 weeks. The survey was running, and distributed via social media and during the Congress. And of course, the participation was voluntary, and it consisted of 15 questions. And we have had more than 250 center participants. And the most important characteristic point, I believe, is it shows the experience of the centers, is then about half of the centers were reported to perform more than 30 ECLS runs per year. And we also more than 30% of the centers were involved in a treatment of all age groups, and the half of the centers treated adults only. And almost 90% offered pulmonary and cardiac support. So I believe this, and we also published the results, and the survey was quite representative with this number of participants. So first question we asked, or one of the questions we asked was, how would you describe the weaning strategy in the patient on VV-ECLS? And there was 4 possibilities to respond. And so there was quite equal, or a bit more, about 40% who said, okay, sedation after cannulation, gradually reduced sedation, then assisted spontaneous breathing is allowed, and then extubation or track after the Ecmo decannulation. The patient is separated from the ventilator after Ecmo decannulation, so about 40%. And then a bit less, about 30%, sedation at the beginning, so the same steps as we know, and then extubation or track during Ecmo, and patient is liberated, separated from the ventilator before Ecmo decannulation, awake Ecmo weaning. So it's not bad. I believe it's not bad. 30% of the centers responded like this. And we will see in the further question results. There are some pitfalls about this. So 90% of the centers titrate sedation due to a specific score like RAS and Ramsay. About 50% perform track, and the track during the ECLS run, mostly between days 7 and 14. So it's also, I believe, the first step to weaning from EMV, from invasive mechanical ventilation during ECLS support, and to the attempt to wean ventilator first before ECLS decannulation. But what is the reality the reality is that 75% of the patients were extubated after ECLS decannulation in this survey, and 12% of the patients were awake and not intubated during ECLS. So, but this group is completely different because, as we know, it's almost a patient on the transplant list, and they are not intubated and ECMO supported. But this is a reality: extubation after ECLS decannulation. The timing of extubation, as we said, and then the estimated percentage of the and number of ECLS patient is extubated while on ECLS. So it's less than 10% in 80% of the centers. So we have still a long way to awake ECMO in a non-transplant patient. The way to awake ECMO in non-transplant patients is still a long way, I believe. So weaning strategy regarding to the reason of respiratory failure is also depending. So everyone said, okay, you cannot wean every patient as the same way. You have to differ between patients await lung transplant. We tend to avoid or extubate patients with acute COPD, and this is the group which is, I believe, the most problematic group, RDS patients, because there are so many processes and their weaning process is so complex, but people tend to discontinue. So people try it, and centers try it, and I believe this is the right direction, and this is a good perspective we have for the patients. So and the last but not least is what we wanted to know, the reasons why ECLS team members do prefer to extubate a patient on ECLS. So extubation comes first, or to stop ECLS while continuing mechanical ventilation. So discontinuation of ECLS comes first. And we may see the numbers. It's everything about between 20 and 30%, and this is what we ask. Was, for example, extubation come first because it's decrease the risk of ventilator associated pneumonia. So this is one of the reasons why we should extubate the patient. Extubation come first because it's associated with less muscle weakness, including diaphragm. So people also, 1/3 of the centers believe it's worth to extubate before ECMO discontinuation. Extubation comes first because it allows optimal neurological assessment and contact between the patient and the relatives. And I strongly believe in all kind of prolonged ECMO support, it's almost impossible not to contact the patient on the ECMO, and we should also have the possibility to discuss the patient wishes with them. So this is the essential part and the essential argument. Excuse me. It's not COVID. It's just talking too long. So it's an essential argument to communicate, to have the opportunity to communicate with the patient especially during the prolonged ECMO support, and to extubate them, or even on the truck. Then why do people believe we should discontinue the ECMO first? It should come first because it allows a stopping of anticoagulation. So we mentioned this problem. It's always the balance between the risk of thrombosis, between the risk of clotting, and the amount of anticoagulation, and in a special groups of patients like maybe trauma or any blood disorders. This may be an argument why we want to have ECMO out and not to have these interactions between anticoagulation and the membranes and bleeding risk. And then this is why what makes us sad, because still 1/3 of the centers believe we should discontinue ECMO first, because managing the awake patient on ECMO is too difficult and risky. And this is what I believe it needs more discussion about this, more maybe also a kind of simulation or more support, also how to manage it, and how not to manage the sedation, but it belongs like pain management and anxiety. So anxiolytic drugs and how to use these agents, and not just to sedate the patient, put in sleeping, and then ECMO runs and everything is all right. It's not all right, and we all know the long complications, prolonged complications of sedations are also very life-threatening, and we don't want to have them all. So this is how we ask for the reason about the reasons and what people think, and let's summarize our results of the survey. So we have seen significant differences in management of invasive mechanical ventilation, sedation, and ECMO during ECMO support among centers and clinicians as well. And the main result, or the main our conclusion was that one out of 3 participants consider weaning of mechanical ventilation before ECLS, which demonstrates a growing perception about the feasibility of awake ECLS, also in non-transplant patients. So this is how I mentioned in the result part, and this is our conclusion. And talking about awake ECMO, do we have pros and cons, and just short steps through this? What are the benefits for the patient about spontaneously breathing, optimal ventilation perfusion matching, functional residual capacity, less atelectasis? It's more physiological, I believe. We also avoid ventilator-induced diaphragm dysfunction, decrease in intrathoracic pressure, improved cardiac filling, cardiac output, lymphatic drainage, and probably this is what the participants of our survey also believed. We avoid the ventilator-associated pneumonia if no intubation, so no tube, no infection. And the question is, if awake ECMO is more physiological than invasive mechanical ventilation, because we have a quite well-preserved physical condition, active treatment participation, less delirium, ability to eat, drink, communicate, and all those arguments are beneficial for the patient. And some contraindications, and this is especially in this severe RRDS group with hemodynamic instability, is also patient discomfort, pain and anxiety, risk of invasive device displacement. So if the patient is in quite a severe condition and will remove his Ecls accidentally, and he cannot be ventilated immediately, it's the risk of cardiac arrest, even cardiac arrest due to desaturation. And we have some interactions with positive transpulmonary pressure in similarity to mechanical ventilation, if the airway pressure minus pleural pressure are positive, and also lung damage risk, which might derive from spontaneous hyperventilation. If spontaneous ventilation induce lung injury, if their breathing efforts are too consuming, to metabolically non-beneficial. So also high O2 consumption, and high CO2 production, high cost of breathing may turn in worsened hypoxemia and muscle exhaustion, which all is non-beneficial for the patient. So let me summarize this topic. And what we have seen is the variation in the VV Ecmo weaning management strategies between centers, and it also may be influenced by case mix, experience, and volume. So we suggested after our survey further research how clinicians and centers decide and in favor of weaning from invasive mechanical ventilation before ECLS. And the recommendation about the weaning process, last but not least. So maybe it starts at the moment of the cannulation, but not always in case of prolonged respiratory support. Weaning process is possible after certain criteria are achieved, like recovery of lung compliance and, of course, underlying disease. The optimal weaning strategy still remains unknown, unfortunately. And the main adjustments are blood flow, sweep gas, and gas composition. And again, weaning does not mean ECLS decannulation and liberation. Weaning is a complex process, and I believe we should put much more attention to this. So thank you for inviting me to this presentation, and some more words to EuroELSO activities and to audience from Europe. So we still have a survey generate which aimed to perform the Ecmo provision in Europe. So please participate. You may find the link with this QR code. And as well, I would like to invite everyone to virtual Congress of EuroELSO, which will take in for weeks at the beginning of May. So you all are welcome, and thank you for your attention.
Thank you, Dr. Swol. Excellent presentation. Thank you. We have a ton of questions like usual. We have about 4 minutes to our next speaker, but thankfully you said you will be able to join us at 15:10 Eastern for a panel discussion. So we'll hold for some of those questions then, but you really nailed it on the differences that people have in weaning processes of VV ECMO. But I think one of the main things that we need to, one of the questions I have before we leave you in this session is that many of our audience panel have asked about COVID versus non-COVID patients on ECMO, and has weaning or CO2 retention, or have those limitations changed at all between the two groups? I was at one lecture recently, and the patients that came off ECMO, many of them had to go back on in the COVID group. I don't know if that's your experience or not, but can you make a quick mention of that, please?
Yes, unfortunately, yes. So COVID destroys the lung, and so what we have. So we of course we need more data about COVID patient, but what we have this European survey initiated by Roberto Lorusso and Euro ELSO steering committee and Jan Belohlavek, and so there's a weekly. The weekly results are also posted and tweeted, and what we seen in the preliminary results then in the second and third wave of COVID, and in this new variant of SARS-CoV-2, the ECMO runs are longer, so that we have more prolonged runs. We have a bit, but it's not confirmed. We and it should be confirmed, but it may happen that the outcomes are a bit worsening in the second and third wave, but it doesn't mean ECMO doesn't work. It means the patients are in these severe conditions, and the discussion is upcoming. What Janelle Badulak and also Alexander Supadi, they released this manuscript about to discuss if if we should consider ECMO really for all patients in COVID, or for example for all young patients, and if it should be some limitations, because we see really disastrous destroyed lungs and prolonged runs, and it's really difficult. And also regarding weaning, it's difficult to say, and I personally believe we will see patients who need second run of ECMO due to post-COVID respiratory failure, or post-COVID interstitial lung diseases. So we have patients who have post-COVID symptoms 6, 8, or 9 months after COVID, and the first lung transplant cases are reported after COVID. So the last recommendation for COVID patient cannot be given at this time, because we also wait for herd immunity, and we hope the vaccination process will increase the herd immunity, and we will have less COVID patient, and then we may probably provide not better, but I don't know if more sufficient, but more satisfactory care if we also have more data, because what we are doing now is just like tapping and like a like sometimes maybe like a blind flight because of many uncertainty we have, unfortunately. I'm sorry for this statement.
No, but it's so true. Again, I thank you. You probably don't see all the thank yous coming from the audience and the excellent lecture and all the positive feedback we're getting, but it's plentiful. So we look forward to you joining us later at 15:10 again for the panel discussion if you can make it. Again, love you. Talk to you later. Thank you again.
Thank you. See you in 2 hours. Bye.